I hope I don't run over, but I have a lot to cover in 15 minutes, so I'm going to get right to it. We've had some really amazing progress in the past 10 years in terms of developing prognostic models, assessing risk, finding new ways to stage the disease in PBC, and really allow our patients to look forward to a long, if not normal, life expectancy. And now we have exciting new therapies that are focusing on patient-reported outcomes and quality of life. So here are my disclosures. So one of the things that I want to start by mentioning is that our concept of risk assessment in PBC is evolving. We used to think that it was really just stage of disease. Then we developed prognostic models with alkaline phosphatase and bilirubin, and those have really gotten fine-tuned over the last few years. But several new pieces of work have come to light recently. First is racial disparities and the influence of race. And in fact, Dr. Lily Dara, who's here, just had a paper on Hispanic patients with PBC and their outcomes. Dr. Gordon from Detroit has been publishing for a while on the experience of Black patients with PBC, and they can be quite different. So keeping in mind racial determinants and racial diversity is very important. There may be differences in prognosis. Age at diagnosis is now really, really important. So we know that patients diagnosed before age 43 have a very different outcome. Patients diagnosed before age 62 have a different outcome, and older patients tend to have a more benign outcome. Sex has always been an important point in PBC. We always thought that the sex ratio was 9:1, but I was recently in Italy, and the data from Europe, where there's more testing and possibly more evaluation, suggests that the sex ratio for men and women with PBC may be as low as 5:1 or 6:1, not 9:1. And there are some data with concern about liver cancer risk in men, but a very nice paper from University of Miami with Dr. Binu John has shown that, in fact, HCC risk may not be different in the VA population. Antibody profile is important. We know, for example, patients who have the GP210 disease-specific ANA have worse outcomes, and we obviously recognize that there are biopsy features that might be important. Incomplete response to UDCA is well recognized now as a risk factor. So I like to think about classifying risk in PBC in this manner, which is really stratifying the patient into average, intermediate to high risk, and then advanced disease, with the average risk being the patient who has a mild elevation in alkaline phosphatase, normal bilirubin, normal albumin, and has minimal or no fibrosis. Whereas patients who have advanced disease, obviously we as GI hepatologists are very comfortable with identifying who needs early referral for liver transplantation, and we're recognizing that we should be more focused on fatigue and pruritus. But the patient who has younger age at diagnosis, persistently elevated alkaline phosphatase, maybe not an abnormal bilirubin, but a total bilirubin over 0.6, may be somebody that we might consider a high risk, and fibrosis, of course. So personalization based on risk profile is becoming more important. Now, we've all known about the Barcelona criteria, Paris 1, Paris 2, Toronto, et cetera, and we have used these dichotomous models to predict outcomes based on global PBC study group. But we also know now that the development of the Globe PBC score and the UK PBC score provides continuous risk assessment rather than based on dichotomous variables such as bilirubin or alkaline phosphatase below or above a certain cutoff. And so I think that's something that's really important. By incorporating these into your clinic, into your assessment with the patient, I think we can do a much better job in risk assessment for the patient over a longer period of time, and we can reevaluate this, and patients can evaluate this based on their own laboratories. So we have dichotomous criteria and more composite continuous criteria that once again have really moved the needle forward because we're able to risk assess patients over 10 years and longer, as opposed to the old Mayo risk score, which was really over a 5-year period and really determined patients in terms of priority for liver transplantation. And we also know now that responders do much better than non-responders, and there are several recent data that even have provided even more granular information on assessing this from real-world cohorts. So liver stiffness measurement is now well established as a risk prognosticator in PBC. And this is, a lot of this has been driven by Christophe Corpechot in Paris. And it just shows you, for example, that combining GLOBE score, which is based on blood tests and age, and looking at FibroScan or liver stiffness measurement at diagnosis and then follow-up, can provide cutoffs that are really useful. So for example, if a patient has less than 8 kilopascals, they have very, very good outcomes. More than 10 would put the patient at risk for moderate to advanced fibrosis, and higher than 10 would be patients who will have advanced fibrosis. So we can combine liver stiffness measurement and GLOBE score to really evaluate clinical outcomes more effectively. Now, this is a paper we recently published, and with data shown on the right. We have these dichotomous variables that we've used historically, and that's been a criteria for entry into clinical trials, and it's been a primary composite endpoint for response in clinical trials recently with several therapies. And that's been useful, but they're really based on assessment at 1 year after starting URSO and then at periodic intervals. And we know, for example, bilirubin has a continuous function in terms of predicting outcomes, as shown on the left from a paper from Marilla Perez that was published in 2020. Shown on the right is data from a claims database and real-world evidence where we looked at risk of hospitalization, risk of liver decompensation, transplantation, so mallow, hard outcomes, however you want to call it. And we tested the hypothesis that, in fact, area under the curve might be a good way to think about stability for the patient. So this looks at what percentage of the time under observation did the patient have an elevated alkaline phosphatase and an elevated bilirubin. And as you can see, the higher the percentage of time that they were above these variables, these threshold levels, the greater the risk of adverse outcomes. Intuitively, that makes sense, but we haven't really thought about thinking about that. But it has clear implications when we're talking about therapy, because it really reminds us that we don't just test the labs once a year and not think about it in between, that we want to look at the patient over time and try to maintain them in that biochemical response for as long as possible. We have another paper that we just published showing, in fact, the relationship between treatment persistence and outcomes. And it shows that patients who have breaks in therapy and patients who have shorter duration of therapy over time have worse outcomes in terms of hard outcomes like decompensated liver disease, et cetera. And that was in Elementary Pharmacology and Therapeutics also. So I would encourage you to look at that paper. So we know that the thinking is evolving. So we're not just testing a patient at diagnosis, waiting a year on URSO, seeing how the patient does and risk stratifying them. We're gathering data at baseline before we start any therapy, and we're trying to calculate their risk continuously over time based on a variety of different factors. And this is now starting to come out in terms of publications, where you can see on the left, baseline liver stiffness predicts outcomes, and also change in liver stiffness over time is also associated with an increased hazard ratio or risk of adverse clinical events. So again, a very sort of intuitively obvious thing, but something we're now starting to get data to show. So when you look at prediction models, they're complementary to fibrosis stage. So one of the other things that we're sort of trying to encourage people to do and trying to do in our own practice is to incorporate where is the patient in terms of their biochemical tests and what is their stage, because they're complementing each other in terms of predicting outcomes. So one way to do this would be look at the GLOBE score after a year of urso therapy, look at changes in serum bilirubin. If it's over 0.6, that might put the patient at a higher risk category, and then use those dichotomous variables, but also consider including something like FibroScan. So with that, let me talk about treatment. So we all know urso is accepted as first-line treatment, but many of us haven't seen these data in a while. But if you look at some of the early data with urso, you can see that urso was very effective in lowering alkaline phosphatase. And in fact, when urso was approved in 1999, 97, 99, we were able to show from large cohorts that it reduced the need for transplant. And in fact, the number of liver transplants for PBC has gone down continuously since that time, but the average age of transplant hasn't changed. Again, identifying the population with severe disease that we need to be mindful about. And there's no question, it's been a while since some of you may have seen these data, but there's no question that if you look at urso and long-term survival, there is a clear benefit in terms of hazard ratio of almost 50% reduction, more than 50% reduction with urso therapy in terms of need for transplantation. So it doesn't just improve the blood test, it actually improves outcomes. So with that, let's move on and talk about PPAR agonists. Obviously, obeticholic acid is now not available and was withdrawn voluntarily by the manufacturer, but we have elafibranor and seladelpar, which were both approved in 2024. Elafibranor being a dual PPAR alpha delta agonist given as an 80 milligram tablet based on the Elative trial and approved in various regulatory jurisdictions, with seladelpar being a PPAR delta agonist given at 10 milligrams daily and approved now also by the FDA, the EMA, and in the UK as of last year. So here's the pivotal data with elafibranor. Here's the treatment difference of 47%. And I think it's important for us to always be thinking about treatment difference rather than just looking at the response in the treated population, because the placebo response rates seem to be variable. And these are obviously not head-to-head studies. But very impressive reduction in alkaline phosphatase of 47%, so highly statistically significant in terms of reaching those what we now call POISE criteria for the original POISE trial of obeticholic acid, patients reaching alkaline phosphatase less than 1.67 with at least a 15% reduction, total bilirubin below the upper limit of normal. And here's the rate for normalization. We didn't see this with obeticholic acid, and this is for reasons that we don't have time to get into, but clearly we're now starting to see normalization of alkaline phosphatase with PPAR agonists, which is very exciting and really showing us that we can achieve what our goal is of complete biochemical remission. You see a nice steep reduction in alkaline phosphatase as early as 4 weeks into treatment. With pruritus, you can see that with the Elative trial, there was not a statistically significant difference in terms of response in patients with moderate to severe pruritus, but there was evidence from PBC-specific itch measures such as PBC-40 itch domain and 5D itch that suggested improvement with elafibranor. And this is very reassuring because, in fact, with obeticholic acid, as we all know, itching got worse. Here are the adverse events, and you can see that, in fact, these studies, both the elafibranor and the seladelpar, which I'm going to show you in a minute, were done during the COVID-19 pandemic, so that is a number one adverse event in this particular study, but they're largely GI related with a few other side effects, but discontinuation due to adverse events appears to be not different compared to placebo, and severe adverse events seen in about 11% of the population. Now, response was a study with seladelpar, and again, very nice difference in terms of seladelpar treated versus placebo treated patients with a treatment difference of 41.7%, again, highly statistically significant, so a very impressive result. Here we were able to see alkaline phosphatase normalization in 25% of patients at 12 months, and a similar prompt and sustained reduction in alkaline phosphatase that occurred at baseline at 4 weeks into treatment and was sustained over therapy. With Seladelpar, we did actually also observe a statistically significant difference in terms of worst-itch NRS in patients with moderate to severe pruritus, and this was very impressive. And you can see that, that this was a change that appeared at 6 months and was sustained over the course of therapy. Side effects with Seladelpar, again, COVID-19 being the number one, with a similar type of GI-related side effects that we've come to expect from the PPAR agonists to be clustered with a few other side effects that seem to be present at maybe numerically slightly higher rates than placebo. But once again, adverse events resulting in treatment discontinuation, in fact, not different and in fact lower than placebo numerically here, and serious adverse events in a comparable number of patients. So in summary, risk stratification is important in PBC. Hopefully I've given you some new ways to think about this. Should accompany assessment of disease stage. URSO clearly improves long-term outcomes. Second-line treatment, we're fortunate to have 2 therapies that are now highly effective, and we need to consider this early based on biochemical response stage and patient risk. And we have data with the PPAR agonists suggesting improvement in pruritus, which I think is very encouraging, and alkaline phosphatase normalization, which is also encouraging, and confirmatory trials are ongoing. Thank you very much.